Hey, good morning, everyone. This is Republic Pain Specialist Josh Dunlap and David Gaskin here. We've been trying to put out a little more educational information for y'all regarding the Stellate or any other pain procedures that we do. Kayla was wonderful and sent out a request for what's your questions. So some of the questions that people have gotten and sent to us requesting information about the procedure, we're going to try to answer for you. So we got a whole list of questions, so we're going to try to work through them for you. So one of the first questions is for David. If it didn't work the first time, right and left, is it worth trying again? In our experience, is sometimes apparently is a building, and so the answer is yes. Not as likely in my experience, or Josh and I's experience, is not as likely that it will, if you got zero response from your first right side, your second left side, you're much less likely to get a result. You agree?
Yeah.
From a repeat right and left. So in that scenario, what we would rather do than go immediately to try another set of injections is, I think what we're really seeing a better result from is start trying to exercise and strengthen that autonomic system. If we can get that system in a better condition, in a better health, then we notice that you improve more. So we start autonomic training, breath and cold work, and then ask you to come back.
It's almost like you're getting primed to receive the Stellate, to get results from the Stellate before you get a repeat.
Exactly. So an add-up question was, would you do anything different with the injection itself? I won't. I just won't. We've done almost 1,600 people, 2,400 injections, I believe, 2,500 injections, Stellate ganglions at this point. They were saying if it ain't broke, don't fix it. So I'm not going to experiment with you or one of my patients. We know what we do works for the vast majority of people. I'm not going to change that.
I agree.
Okay.
I've got one here. If I want to repeat the injections to improve my success rate, how long should I wait in between? I routinely see folks, and I kind of have half and half. I see some folks that get success immediately, and I also see folks that get success a week out, all the way out to about 4 weeks out. It may not be that initial big change that you have right afterwards, but we get phone calls all the time about people getting better about 4 weeks out. I would say what you're holding on to, what you gained at that point, you're going to keep. And that's what I tell people all the time is let's give it at least 4 weeks and see what you get, what you hold on to before we do any kind of repeat. In addition to doing, like you said, autonomic training, breath and cold work, anything we can throw at it. So
yeah, and everybody's different. Some people will stop improving at about 2 weeks, but other people will send us notes that at 6 weeks they were still gaining food. So I would say listen to your body. If you stop improving, that's a good time.
Yeah,
that might be 2 weeks, that might be 6 weeks. So who knows? So next question: what if I got a great Horner syndrome, but zero to little results? This is this is exactly what we see more and more, and I think it probably goes because our name's getting out there. We're getting some of those harder cases, those ones that they've had Stellates other places and they didn't get results, and so now they're trying us for some reason. And I've seen the most I've seen is 5 Stellates that a lady got from other places. Came to us. I was very surprised that she tried a 6th time when 5 didn't work.
Yeah.
But she left with 85% success. So the deal is it's done in a lot of different ways. I can go buy a car, and I'm not degrading other people who do this, but I can go buy a Chevy or I can go buy a Mercedes. A car's got 4 wheels, steering wheel, brakes, yada yada yada. But there's different ways of putting that together. The stellate ganglion block can be done in many different ways. It can be done with ultrasound, or it can be done with x-rays. It can be done at one level, the stellate, or it can be done at two levels, the middle cervical ganglion and the stellate ganglion. It can be done with a long-acting local anesthetic or a short-acting local anesthetic. All of these things matter from what we've found and experienced. It matters how you do it and what you use. We believe ultrasound is the way to go. It's absolutely the safest, most accurate way to place local on the stellate ganglion. Our experience is that it's lidocaine. It's a short-acting but a very dense, dense block of the sympathetic nerve, and it's that dense, quick shut-off that causes the brain to do the reset, for lack of better understanding of what's happening in the brain. Those people that are using long-acting locals, they're getting a Horner's, but it's taking 5 or 10 minutes for that long-acting local anesthetic to create the block. If you give the brain 10 minutes to adjust to something, you're never going to get that reset, or not nearly at the success rate. So, and I think that's what we're seeing around the country is people that are using the long-acting locals are falling in that 40 or 50% success and not 90%. Okay.
Got another one here. How many patients do you see that end up being left-sided dominant? I'm assuming they're asking, there's a dominant side, just like we are right versus left-hand dominant. There's a dominant side that we have that has control of that sympathetic tone. I would say that the majority of folks are right side dominant. They've done anatomical studies to show that the right sympathetic side is dominant. But not everybody is dominant. I would say it's probably 80-20, 75-25, around there. I would say the majority of folks for sure are right side dominant, but not everybody. We do see periodically that somebody does a right side, they don't get, they may get a little bit of response, a little bit of improvement. They do the left side, they get really good improvement. So that's something, unfortunately, that's impossible for us to look at somebody and say, you're right, you're left. There's no physical way that we can do that. But just from experience and the numbers that we've done, that's what we've seen. I'm sure David.
I agree. I think it's like 80-20. And we haven't, we're a private practice that's small, and we can't count everything. I know people want numbers and percentages, but just an estimate is 80-20. But it's certainly not unusual to see 20% from the right, and then they go to 70 and 80% from the left. So still good. Should we start the breath and cold exercises before we get the procedure? And then I'm assuming how long until we see results. I'm assuming of breath and cold. I want it as early as possible.
For sure.
I don't know that you could do it too early, or if there's, if you would start it a week before, I think that's better than not starting it at all. Just give you my personal experience. I had rheumatoid arthritis and parosmia. Breath and cold cured my rheumatoid arthritis. I'm off all medication, but it took me 9 months to get there. It took a long time. It wasn't that quick fix like maybe a Stellate is that quick fix, but it is going to strengthen that system. It's going to improve that system. And what we're seeing is that if we can get them doing that 4, 6, 8 weeks before they come in for their Stellate, it may not reverse your smells. It may not improve your smells, but that internal system is in better working order. It's primed to get help and get the reset. I'll say this, I don't think anything is the holy grail or the silver bullet that's going to fix everything. It won't be breath and cold. It won't be the Stellate. It won't be one thing. It's not a TENS unit. It's not this and that. But when we combine them together, I think we can see some of those very worst cases improve.
Absolutely.
If you're only doing breath and cold, I can tell you it's going to take about 5 or 6 weeks before you start seeing changes in your body. With temperature auto-regulation, being able to maintain the cold, you're going to see your breath holds get longer and longer as you get to the 3 and 4 and 5 week time. So it'll take weeks to start seeing a difference in your body with breath and cold.
Let's see, is there anything else we can do to help our bodies and minds prepare for the injection? What can we do after to maximize the benefits? This is something I hear a heck of a lot. I think in the realm of treating this and, parosmia, which we believe is just a dysfunction of the autonomic nervous system, if we can do, we need to be doing the things that we know are good for our bodies. We need to have a good, clean diet. We need to be exercising. We need to be getting enough sleep. That being said, it's hard, right? When you can't smell and taste correctly. Like David kind of alluded to earlier, doing breath and cold, I think is vital. We're trying to do anything possible that we can to increase that parasympathetic tone, decrease the sympathetic tone. Acupuncture, yoga, meditation, these things all activate that parasympathetic system, as well as cold water exposure. You can do that by, we can stimulate the parasympathetic with cold water. We can also do it mechanically. We can stimulate that vagal nerve. Sounds kind of silly, but singing, humming, talking, all these things mechanically stimulate that vagal nerve. Anything we can throw at this is not going to be a bad thing. Just like anything else, when we treat something, a multimodal approach, not just relying on one injection each side. Yes, we know this works. Yes, we know that this can change a heck of a lot, but why not throw everything we have at it? Because these folks suffer so much. So it's just kind of my thought. What can we do to maximize the benefits? Continue this. I think just like anything, you guys have been suffering for so long. You've had parosmia, you've had all these post-COVID issues, and you get this almost like euphoric high afterwards because things don't smell as bad, taste as bad, or normal. And I think a lot of folks just kind of, let that past year or two that they go by. I think it's vital to continue with breath and cold, continue with anything you can do to keep this going. And our thought is that if we can buy ourselves and buy our brains a period where we're out of this sympathetic drive and we can find, reorganize, find a new set point, hit that reset, anything we can do after that, pardon me, to prolong that is only going to help, and it's only going to keep what we gain after that.
Okay. All right, me again. If I get COVID or another virus infection, will I regress? What's your experience with this? There's so many variations of people's responses. I don't know that you have to be so afraid of COVID. In fact, this is going to be a crazy, I don't know that it was all COVID. So many people come in that have two autoimmune diseases, and they've been suffering from a degree of autonomic dysfunction for many years. Their body was primed for years prior to catching COVID that made their insomnia, that made their headaches, that made their fatigue, that made their IBS, that made all of those symptoms simply worse. Yeah. It wasn't that they didn't have those symptoms prior to catching COVID. Right, it just amplified everything you had been living with prior to ever catching COVID. So the fear of that now becomes, will the next cold, will the next any illness, if your gallbladder goes bad and you have to have surgery, if you have a back surgery, what pain drives the sympathetic system so much? So I'll say this is even more emphasis that we need to be doing something to strengthen that system so that it is stronger to resist the next stress, the next sympathetic drive load that your body's going to be put under. You cannot avoid stress in life. You can't hide in a closet the rest of your life. You're going to have to go out. You're going to have deaths in families. You're going to have financial troubles. You're going to have toxic work environments. These things are going to happen in life. They're all stressors that could cause you to revert back if that system's not stronger. So I've seen people that they're, the most unusual one is a lady called me and said her son got suspended from school. He got in trouble in school, got suspended. That was such a stress on her body. That's all it took. And overnight she lost it. So it's not just COVID. You need to be thinking about how do we strengthen that body so that no stressor can ever get us back to where you are right now, okay?
Let's see, what is the pulsed radiofrequency ablation and when or who should get it? We start thinking about a pulsed RFA, and Dave and I just had this conversation the other day. The Polestar FA is essentially the same thing as a stellate ganglion block. The only difference is we use a special needle. The very tip of this needle heats up to a very specific temperature. That's about 103 degrees or 42 degrees Celsius. So what this does, it modulates the nerve. It doesn't damage the nerve, doesn't hurt the nerve, but it modulates the nerve. So we get the action of a stellate ganglion block, but we can get it for anywhere from 3 to 6 months or longer. Some people are longer, some people are shorter, but that's kind of the average that we get. The thought is that, if you get a stellate ganglion block, get good results, and then you regress, like David kind of alluded to, maybe it's stress, maybe it's something, that is weighing on that autonomic nervous system, causing you to slip back into an elevated sympathetic tone. If we can do this, it's almost like buying ourselves, 3 to 6 months of having this decreased sympathetic tone so that our bodies can reorganize, reset, and fall back to a normal, they call it auto-regulation. Our bodies are very good at regulating itself between a high and low parameter. If we make conditions right for that to happen, then, our bodies can reset and get back to it. So I would say, typically we don't just jump to that. That's something that I want to see if we can, at minimum, I would say probably 2 sets of a right and left, getting good results each time before we would consider that. And this has to be kind of a shared decision-making process. We can't make that decision. You can't just say, hey, I want a Polestar FA. This truly has to be something that you understand, something that we both kind of come to an agreement on. I feel it works just better that way. So hopefully that kind of answers that question. Answered the how long should we expect those results to last. Does it hurt? 103 degrees Fahrenheit, but you don't feel that at all. Your body temperature on average 98, 99 degrees. A few degrees above that, you don't even feel it. We don't even put a local there before. We localize the skin, but we don't actually localize the stellate ganglion because it doesn't hurt. So hopefully that helps with that question.
And a big key point is that there's no cellular damage.
Correct.
Yes, it is super safe.
Yeah.
That wasn't part of the question, but
yeah.
I think when people are looking at radio frequency ablation, RFAs, compared to pulsed radio frequency ablations, using same needle, same machine, same concept, but because the temperature never gets above 42 degrees Celsius, there's no cellular damage under microscope. So it's very, very safe in a location like the neck where there's a lot of stuff there we need to be cognizant of, versus doing something in the spine where we routinely use 80 degrees Celsius. So safe, but still not something we want to go to immediately, okay? Sorry, I had to add.
No, that's good.
Sorry
That's good.
That.
That's good.
Sorry about that. If I'm at 80%, would you do it again to try to get to 100%? Hell yeah. Why, who wouldn't? I mean, why?
Yeah.
Your body has shown that it's receptive, it's capable of responding to the stellate. I think we see people get so good with one that it's kind of been accepted that we're just going to do a stellate and see if we're healed. Yeah. If I were treating, or we treat PTSDs, anxieties, depressions, severe depressions, complex regional pain syndromes, we treat all these other elevated sympathetic states with a sympathetic nerve block. Yeah. But we would never tell any of those patients, we're going to do one and see how you do. Yeah. No, we're telling them you're going to probably get 6, 8. I don't know how many you're going to get, but it's going to be more than one.
It's usually a series.
It's a series, and so I don't expect you to go to 100%. Of those 1,600 people we've treated, there's a very small number that get no response. There's also about the equal number that go to 100% on the other spectrum of that scale. The vast majority fall in this big bell curve of 60 to 80%. So it makes perfect sense to me to say, if you're not 100%, an additional block later down the road will probably get you much closer to that, just like we see with PTSDs, anxiety suppressions, or complex regional pain syndrome.
All right, got another one here. Does the SGB hurt? I hear this, almost every patient asks me this. From personal experience, I can tell you the idea, I think, of a needle just being in this area is hands down the worst part of it. You feel, we use some cold spray, we numb the skin up with the cold spray. We use just about the smallest needle they make, actually. It's a 25 gauge needle. So all these things combined, what you do feel is just a slight bit of pressure when we inject the medication. And it's so temporary. I mean, the whole thing from start to finish truly is less than 2 minutes, if even that long. Dave and I have done thousands of these blocks, and so it doesn't take a long time to do it, accurately, repeatably. So short answer is no. The idea of the SGB, of a needle being in your neck, is for sure the worst part of it.
And I tell people on that, there's a difference between uncomfortable and pain.
For sure.
It's gonna be uncomfortable.
Yeah.
Nobody likes having a needle stuck in their neck.
Right.
Nobody,
Yeah.
well, y'all are choosing to do it, but what I'm saying is nobody really wants that. And so it's gonna be uncomfortable, but I think there's a difference between uncomfortable and bordering on painful.
For sure.
So it doesn't hurt, no promise. For me, what's the difference between lidocaine and ropivacaine? Ropivacaine is one of our long-acting local anesthetics. Lidocaine is that local anesthetic that is the shortest acting. We have really became total converts that lidocaine is the answer for this, or certainly a big component of it, of the success that we're having. There's ideas out there, theories of how to treat this. There's obviously some people think you have nerve damage. We don't think that. We think it's the autonomic system. Some people think that even within the stellate ganglion block, that you need to shut that system down for a longer time to allow the body to reset to that. Our theory is exactly the opposite. It's not how long I shut it down, but it's how I shut it down. Did I shut it down hard and fast and very densely where I shut off that nerve supply? Or did I shut it off very slowly for 10 minutes and then create that block for 6 hours? So there's a total different idea behind it. Ropivacaine is going to take 5 to 10 minutes to create that nerve block. So we call it slow on and slow off. It's going to be slow to set up, but slow to leave. Lidocaine is our shortest acting local anesthetic, but actually the fastest onset. So literally in 2 seconds, you're going to have a very dense block of that sympathetic drive, but it's going to be gone in 15, 20 minutes. So ropivacaine is considered safer than a marcaine or bupivacaine, but it's still very dangerous if it gets in a blood vessel, if we inject it intravascularly. It is safer than marcaine, but I'm telling you, in the neck, with it going to the brain, an intravascular injection is likely going to stop your heart. Lidocaine is one of our first-line advanced cardiac life support drugs. It's one of the safest local anesthetics that we can use. Both of us have given anesthesia for a total of close to 35 years, okay, of experience. Almost every anesthetic that we gave, general anesthetic, we pushed lidocaine intravenously on every case. There is not a safer local anesthetic on the market, period, hands down.
Agreed. Why do you use steroid and some people don't? That's a good question. So if it ain't broke, don't fix it, right? No, so, and the thought is, and again, our background is anesthesia, ultrasound guided regional anesthesia. When you add a short acting local, Decadron is what we use. When you add that to a local anesthetic, it does a couple things to the local. It changes it a bit. It makes it a little bit more dense. It also increases the duration of that lidocaine. Our thought is that if we can get a more dense block of that stellate ganglion, we can get a more dense, a quicker, harder reset. And again, after doing thousands and thousands of them working, we don't want to change because it works. So hopefully that helps.
Yeah. Are you seeing the stellate ganglion block help with anything else? I have a friend that has autoimmune disease, and she said it helped her overall. This is good. Y'all are going to cut me off. You're going to cut me off here because I'm going to get on my soapbox. we are now treating it. Okay, let's try to back this up a little bit. The overall sympathetic drive is what we think is wrong in long COVID. Is an elevated sympathetic. That's exactly what's happening in our autoimmune diseases. Autoimmune, the autonomic system's triggering the immune system to send out inflammatory mediators. In rheumatoid arthritis, it's attacking my joints. In Hashimoto's, it's attacking my thyroid. In Crohn's, it's attacking my GI tract. On and on and on. Fibromyalgia is widespread muscle and joint pain. Chronic fatigue syndrome it goes on and on. 63 autoimmune diseases. So, if it's the same elevated sympathetic response that's causing these 63 autoimmune diseases, and I'm not gonna say don't get me wrong, I'm not saying it's gonna fix all 63 autoimmune diseases, but when we're also treating long COVID that we believe is an elevated sympathetic state, if the sympathetic nerve block creates a reset of that system, it would make sense that we're now able to at least reduce the symptoms of these other disease processes. So guess what? Josh and I have been experimenting and treating fibromyalgias, chronic fatigue syndromes, and rheumatoid arthritis with a stellate ganglion block and autonomic training. Let's just call it autonomic training because there's lots of different ways to work on that autonomic system. And we are seeing dramatic changes in chronic fatigue, rheumatoid arthritis, fibromyalgias, and many other things. So the short answer is yes. The longer answer is I need another video to talk more about that.
To be continued.
Yeah, to be continued.
Let's see. Have you had anyone with anosmia due to head trauma or concussion that you have treated with the SGB? I get this a lot. We've had a lot of questions of what can the SGB fix. I have one instance, and this is a very common thing. If you have a head trauma, you get a concussion, you can lose your smell just like that. It's a mechanical shearing injury of your olfactory nerves coming through the ethmoid plate, cribriform plate, where the olfactory nerves live. Those nerves get sheared off. There's physiologically no reason why a stellate ganglion should or would help that, period. And I'm the first to see that it helps quite a bit, but there's absolutely no help with this. I have had one patient that had a concussion about 5 years before. He asked me, "Is this going to help with it?" I said, "Absolutely not," and it proved me wrong. He got smell back after that. So, but out of the thousands that we've done, that's a hard sell, and I wouldn't rely on that one. So I think that's just an outlier.
So on that, what we're trying to determine and we're trying to publish on this, so I'm kind of all into this right now. You can have quantitative loss of smell, meaning that the odors just don't get through. Quantity. The odors won't go through. Yeah. And that's where he's talking about this shearing, and the odor can't get past the cribriform plate. You can have qualitative. Qualitative means I just don't smell well. The odors are going through, but the processing is not there. I don't smell very well. The third thing that we think we're treating with our third ideology or theory of how we get parosmia or anosmia is a more centrally mediated pathology. Yeah. We're trying to treat, and we think the stellate ganglion block treats the centrally mediated pathology, that autonomic control. Okay, so big differences there. Certainly. What's your experience with anosmia, and why don't you think it works as well? Well, we just explained that. Yeah. We just explained that. It's the anosmia is a different animal than parosmia. I think that's a quantitative dysfunction, likely due to some sort of injury, concussions, trauma, shearing, or mechanical, meaning like when you catch a cold and you get stuffed up. Okay, that inflammation and congestion won't allow the odor to transmit into a nerve signal, so it gets shut off. So anosmia is actually something very different than parosmia.
Yeah. Let's see. Are there any common denominators you're seeing with patients who require more injections or don't get as good of results? For sure there is.
That's a big one.
It is, and that's I would, for this one, I would say refer. We have a YouTube video that Dave does a great job and goes really into depth on not just why, the what's in the hows on all this. And so it really will go into that. Just as a brief kind of aside, I think anything that keeps that sympathetic system very ramped up, anxiety, PTSD, bipolar disorder, things that, people have pre-existing, those tend to be the folks that, we see. Also the folks that have, a long-standing history of childhood traumas, physical, emotional, sexual abuse, those kind of things, and so it's hard. We're trying to treat, and I tell all my patients this, I can't undo years of trauma that you've gone through with an injection on the other side of your neck. So with that, not to say that they're not going to respond well or they're lost causes, they just may be a little more difficult to treat and may require a little bit more treatment, a little more in-depth treatment. So, if you fall into those categories, don't think you're a lost cause. There's definitely things we can do to help. But those are kind of the things that we see. But definitely check out the YouTube video. David does a really good job at going into depth and explaining why that happens.
It gets, my heart goes out to when we say the ones that don't do as well are the ones who suffered from childhood traumas, the ones who already have 3 autoimmune diseases, that have been suffering from all these ailments, disease processes for their life, started when they were teenagers or child. Don't hear us say that you can't be helped. Just like the concussion patient for 5 years has no smell, we're sitting there saying it won't work, and it worked. We're just saying you're going to require more work in our experience. You are not a lost cause. We can fix this. I don't care if you've had 5 stellates before. This can be fixed or at least improved. You can get your life back. So don't write it off. Don't write yourself off. Okay. I lost my thing. What do you consider a success? We just made that up. Because we're pain people. If you came in here with a 9 out of 10 rated pain, on a scale of 1 to 10, yours is a 9 out of 10. Trying to be realistic with a patient and get them maybe a long-standing chronic pain. If I tell them, hey, can we reduce your pain 50%? If your 9 went to a 4.5, would you be happy with that? I'm telling you, most patients would be ecstatic if they can get their long-standing pain from a 9 to a 4.5, something below a 5. Therefore, just because I've never had experience with parosmia, when I got this going, and I think Josh has kind of followed some of what I got going, but the idea is, can we improve you 50%? If you've got if you come in and there's nothing good, you have 5 safe foods, okay, and nothing is good, you leave and I send you to Golden Corral, a buffet down the road, and you try 50 things and 25 of them are good, 25 of them are still bad, you're at 50%, but we think we're not trying to gain 100%. We're not trying to gain everything back with one set. We want to try to be realistic and say, can we get some part of your life back where it's better than it was before?
Absolutely. Do you think insurance will cover it in the future for long COVID? I do. That's kind of one of our things. That's why we're trying to publish. We're trying to do research, because just like everything else, we have to prove it to the medical community. When we do that, then it becomes a more accepted treatment. We can say all day of the success that we've had until we show it, until we prove it. I think that's one of the big things, because it is considered an experimental procedure. Even though we're having really good results, through the eyes of insurance, they don't want to pay for it. That's the whole point of insurance, is they deny things. They don't want to pay for. They don't want to pay for procedures. There's entities out there that work for insurance companies. Their whole job is to deny procedures. They get a part of what they deny, so it's in their vested interest to deny as many things as possible. I think this is going to be no different. You'll have some insurances that cover it, and then I think you'll have some that won't. So I think it'll just follow into that category in the future. I hope that they do, though. We hope that they do. This should be available to anybody that needs it.
We've heard of some that got covered, and it may not have been your full reimbursement, but you got part of it back. We'll be glad to give you all your records, all your codes, everything,
See if you can get it
and let you turn it into your insurance and see if you can. one of the things, even if you called and said, hey, my insurance says they cover the SGB, there has to be a medical necessity attached to that. Just because your insurance covers the SGB, what medical diagnosis are you attaching to that? So there has to be, right now in insurance, PTSDs, anxieties, depressions, or chronic regional pain syndrome are the only 4 that I'm aware of that insurances routinely cover an SGB. So there's a lot of combinations there. We'll be glad to help you. If we were trying to establish that, I think what people are wanting to know is, this is out of pocket, can I get insurance to cover it?
Yeah.
For someone from Wisconsin to come to Texas, the first thing we have to do as a practice to try to build insurance for you is to establish you as a patient. So you have to come, we have to do an initial visit, we have to establish you as a patient. Now when we establish you as a patient with a medical diagnosis, we can submit to insurance for authorization to do that SGB. We have to wait. It can take days to weeks for them to approve or deny that authorization. Then, so that means you have to come from Wisconsin, you have to see us, we establish you, establish diagnosis, request approval. You probably have to go back home. When it gets approved, then we can bring you back. If I'm even within your insurance provider, since you're in another state. So this just becomes so complicated and unlikely to get done and too expensive for you to just travel back and forth. What we do is just say, look, we're trying to keep it as affordable as possible. We're not charging thousands of dollars per side. We're saying, look, I can keep my staff, we can keep our staff busy doing injections and not busy on the phone trying to get pre-authorizations, okay? So it may or may not, we'll help you, but it's just too much for us to try to do it across the board. How many patients combined have you treated now? All right, this question came up. I'll be glad to show anybody our books that questions what we do. My wife just ran reports for me last weekend. We were right at just over 1,000 patients in this in this practice. Josh, before he came here, had done about 400. So from a patient standpoint, patients were right over. We did, I don't know, about another 30 this week. So we're somewhere right around 1,450, between 1,400, 1,500 patients. Now you look at how many SGBs that is, actual stellate ganglion blocks. Those 1,400 patients became 2,400 SGBs. Okay, just for paroxysm, not PTSDs, anxieties, depressions, or anything else. Okay,
just a couple.
Yep, a couple.
Let's see here. What is your experience with it helping tinnitus and dizziness? I hear this a lot. Tinnitus. I'm an under promise, over deliver kind of guy. I don't like to sit there and tell you, it's going to fix world hunger and make you rich and all these things. Tinnitus, is a very common long COVID problem. What I can tell you is the majority of folks that have tinnitus as a big complaint, it's almost immediate. And on average, what they say is that it gets reduced about 40 to 60% almost immediately when we put that lidocaine in, and it stays there. My dad had tinnitus really, really bad. Did an injection on him, and he said it was improved as well. Said the same thing, almost immediately. That if I haven't heard anybody that said it just completely goes away, but it gets definitely reduced. And with tinnitus, any improvement is good improvement with that. Yeah. So dizziness, that's a hard one. Again, we don't track every single symptom of this, and the SGB can temporarily cause dizziness afterwards. We're causing a lot of changes, so that's a hard one to quantify. But yeah, we'll stay tuned.
And hey, this is going to be our last one. We're going to shut it down. What other long COVID symptoms is the SGB helping with? I think we touched on that quite a bit already. All the autoimmune diseases. We're really being impressed with the fibromyalgia responses. The fibromyalgia patients, Josh will tell you and agree with me here, very uncharacteristically of any other type block we do, when we do a right-sided stellate, they are like a line drawn down their body and they're pain-free on one side. Every one we've done goes like that, and you have to do the left side to create a left side pain-free. So really, fatigue, insomnias, headaches, joint pains, muscle pains, everything that's related to inflammation or an elevated sympathetic state, increased heart rate, palpitations, cold hands and feet, Raynaud's, constriction of the vasculature of the extremities, so headaches, diabetic neuropathies, we've
Sleep
seen those
quality.
go to sleep. It
Goes on.
it almost goes. I have a saying: I don't know what it won't fix now,
Yep.
or help. Now, I don't want to be promising that across the board. I think
Yeah.
that's irresponsible. But sometimes people say, "Will it help with this?" If nothing else has helped, and there's no other pathology can be found, in my life right now, what we keep seeing is this worth trying.
Sure.
And if your life is better, then it was $500 well spent.
Absolutely. Guys, we appreciate the questions, the interest about the stellate ganglion. If you guys have any other questions, please reach out. Keep the questions coming to us. We're going to keep working hard for you guys. Pardon me. Check out all our other channels, our YouTube, our TikTok, Instagram, Facebook. If you have any questions, please reach out. It's been a pleasure talking to you guys today, and we'll look forward to another time.
Lock on.
Thank you.